Thanks everyone for the time. I realize I'm the last man standing between you and the end of the day, so I will definitely respect that and we'll move quickly. So as John said, I did medical school at Texas Tech, and that really was a fundamental and I would say foundational experience for me in terms of introduction to telemedicine. So my very first encounter was almost 20 years ago. And it was, I was in Lubbock at the medical center, and the patient was a newborn infant, was on my surgical clerkship, working with one of West Texas's few pediatric surgeons at the time, shadowing. And the patient was just a few days old, was in Alpine, Texas, with the general practitioner and the patient's family. And the baby had a abdominal wall defect. And so you can imagine as a parent with your first child, you're in Alpine, Texas, what does this mean? What do we do? And what's life going to be like? And sitting there watching this take place, again, this was, all of us had flip phones. Nobody had, speaking of broadband, that was a fantasy for so many of us. We were still dialing up in 2002. But to watch a live encounter almost 20 years ago, was very impactful because we weren't doing much of a physical exam, but we were communicating, and watched a physician who was hundreds of miles away create a connection with a patient, their family, and their physician in a very stressful, trying time for them, and was able to explain, this is what you're dealing with, here's the prognosis, and you're going to be just fine. And that was really, I think, for me, sometimes you don't really realize you're in a defining moment in your life until you're reflecting on it years later. But it was something that hung with me, that experience throughout my training. And I had the opportunity to go on to Dallas and leave a rural community and work in a hyper-urban community. We had a transplant center and academic medical center, and did that for 10 years, and then had the opportunity to go out to Northeast Texas, back to a rural community, and it really took me back. And we were faced with the same challenges that I saw as a medical student, which was we've got patients who need care, we've got the right facilities, the right tools, but we just lack the specialists to provide the specialty care that really a growing complexity of patients really need to keep the care local. So our group began looking at telemedicine as a way to better serve patients about 11 years ago. Launched our first program. This was in town Sulphur Springs, Texas, if you guys are familiar with it. In 2013, unknowingly built Texas's first 100% virtual ICU. So patients are there in person, staff are there in person, the attending physician is rounding and seeing the patients in person, the ERs in person, but the critical care physician was not there. And so we were able to increase the hospital's ability to handle critical care patients by 400%. And that's now an 8-year-old program. And I know I'm here to talk about outpatient telemedicine and the impacts it can have on a community, but really it started for us taking care of the sickest of the sick and improving out capabilities of telemedicine. And what we unknowingly were doing was keeping patients in a community that otherwise would have left that community. And when patients leave the community to receive care, they establish care. They put down roots elsewhere for their health care. And it becomes where the healthcare leaves the community, establishes at a large urban center, and it oftentimes doesn't come back. But when you begin to keep care local, it stays local, it grows local, and then that becomes a cycle that feeds on itself and builds upon itself. So over years, you build a healthcare ecosystem that just simply wouldn't have existed. And so as we built our very first critical care program, a lot of those patients have pulmonary disease, have lung disease, or they develop lung disease as a complication. And when those patients or those communities are used to patients leaving, then they receive their outpatient care, right? They go see a pulmonologist in the town that they were sent to. So over about 1.5 years of keeping critical care patients local, getting them better, they move out of the ICU, they move to the hospital ward, and then they're discharged. Well, they need to follow up with someone. And after 1 year, the family practice docs in town said, we really appreciate all you've done, but now you need to help us in the outpatient. And so that's what I'm here to talk about today, is really the experience of building outpatient telemedicine clinics and the impact that they can have, and really kind of what's the scope and what can be done through telemedicine in a traditional brick and mortar clinic with the care just delivered virtually. The doctor's there virtually, but the patient's there in person, the staff are there in person, and it's a traditional clinic that I think most people think about when they think about outpatient medicine. So just a little bit about the group itself and kind of the broader work that we do. So our group serves 261 hospitals across 28 states. We've recently combined with, as you can see there, SOC Telemed to now serve 750 hospitals in 47 states. And much of the work we have done, because historically those have been the models of care that have been accepted and implemented, has been inpatient, working inside of hospitals. But like COVID has done so many things, but it's completely transformed the openness and the mindset of healthcare to accept change and to look at alternatives in different models of care. And much of it was forced upon us. It wasn't necessarily willing, but we really backs against the wall in so many circumstances, especially those of us who are serving rural communities. And we've seen the impact. We've seen how it can be very helpful. We've seen where's the scope, kind of what's the ceiling, what can be done, what can't be done. But I think as you see here, there's definitely lots of advantages to implementing telemedicine. So when we think about an outpatient clinic itself, it really looks and feels very similar to a traditional in-person clinic. So it's a brick and mortar building, and I'll show you here, where I would say a customary and usual clinic space. So as you see there, this is our very first clinic we built in Sulphur Springs, Texas, but it looks like a regular exam room. The configuration of the room is a little bit different. You can see that it's actually focused more on a seating area, so that the family, the patient can actually sit across from the physician. What you see on the wall there is the telemedicine station, where typically it's a 50-inch television or 40 to 50-inch television with all the telemedicine equipment mounted behind it. So it's relatively clean in the way it looks, but it's a face-to-face, right? So the doctor's on the screen, the patient's sitting in a chair very comfortably if their spouse or maybe their next of kin is next to them. And then there's an exam table for when we do need to do an exam. But in the room with them is typically a nurse, or it could be a registered nurse, it could be an LVN, or oftentimes it's an MA or nurse aide, but that functions as the hands. And so many people have experienced telemedicine in the home. It's very, very common mode, and there's definitely a role for that. But when you're managing complex patients with chronic disease processes, you're making decisions based on the data that you receive. And if the data you receive is inaccurate or erroneous, you could be making decisions that truly could have negative impacts on patients. And so something as simple as a blood pressure, something as simple as a pulse, is very important to make sure it's accurate. Because if you're treating someone with high blood pressure and they're taking their blood pressure cuff at home, you're not really sure the accuracy of that. Some patients take it and they're doing a great job, and you can definitely trust it. Others, it may be inaccurate. And if they give you a reading that's markedly hypertensive, if it's elevated, and you adjust their medicines, but in reality, it was normal, you could cause them to pass out. You could cause complications, right? So first, do no harm. So that's, as you treat patients that are more complex, having them still in a controlled environment where they come to an established clinic, where staff can take their weights, take their vital signs, have a very kind of normal clinic experience, it can be very impactful to when you're making management decisions and diagnostic decisions. So they come to the clinic. Again, it's a normal waiting room, normal reception area, everyone that's used to and customary. They're brought into the room by the patient presenter, which, as I said, is a licensed healthcare professional of some level. And that patient presenter is the hands of the physician. And so just, I would say, as a usual and customary patient encounter, the patient's brought into the room. The nurse stays by the patient's side throughout most of the exam, and we have an encounter. The physician has access to the medical record because so many medical records today are either cloud-based or there's a remote server that the physician can log into. And whether you're sitting at a computer screen logging on an EMR in the same room, or you're 100 miles away doing it remotely, you're still getting the same data. You're able to see the notes, you're able to see any laboratory medications, notes from the nursing staff, vital signs, so everything you would need in a medical chart. And then the physicians can also do their own documentation remotely, put their orders in, et cetera, and talk to each other, right? Have an encounter, take a history. Again, you're speaking through the system itself. And then the camera on it, the physician can steer. They can go left and right, up and down, fully control it, whatever they look at. And they can zoom in where they could read 12-point font on a piece of paper 14 feet away. So as you're doing an exam, instead of the physician walking up to the patient to maybe look at their eyes, to look at pupillary light or corneal reflex, or if they need to look at something on the skin or maybe a wound, they can just pan tilt zoom and zoom in and see it as if they were walking up to it. And then when it comes time to do the exam, their stethoscope is connected. So it's digital USB connected, so plugged in, wired, and it's amplified. So the physician can actually turn the volume up and turn the volume down. It's kind of interesting to note that the stethoscopes that many of us carry in our pockets it's 200-year-old technology. It was considered cutting edge in the 1800s, and we still use it today. I don't know how many things we use from the 1800s today, but and so oftentimes the digital amplified stethoscope is actually superior to the one we all carry in our pockets. But the nurse will place the stethoscope, heart, lungs, abdomen, listen to the neck for carotid bruits, et cetera. And so the physician can hear that remotely. And so you can have an actual true exam without being in the room. It's the same techniques that we've used to manage patients in critical care and manage patients in ER with acute stroke, just applied to the outpatient, less emergent setting. And all of that takes place in a clinic room. Same footprint, same infrastructure, same building. The only difference is that the physician's mounted and coming to you through the telemedicine station. But as you think about that, the encounter is strangely normal. And what we've seen is a very positive reception by patients. And kind of, I say this in almost every talk I give because it's really true, but it's incredibly humbling to talk about this. Our patient experience scores virtually have actually surpassed our in-person scores. And so if you look at how telemedicine has been received, it's actually overwhelmingly positive for so many different reasons. But so we jokingly like to say in our group that the patients actually like us better when we're not in the room. But I think it proves the point that having a quality encounter is really all about kind of the connection between individuals. And I think all of us have seen it's great to be together in the same room, but sometimes you can have a very high quality, impactful connection as long as you can see each other, talk to each other, and communicate. Sometimes that screen just melts away. And there's very few times in medicine where the doctor and the patient can just look at each other, and really connect. Oftentimes the way things are set up or configured, there's interruptions, or the physician may be sitting sideways as the patient talks towards their ear and they look at the screen. And so you're really locked in face to face and free of distractions or anything else that could pull you out of the room. So that's been, I think, a great experience for not only the physicians to practice, but also to reach those in need, but also of the patients themselves. And so you can think of the telemedicine clinic as you build out clinics. And I'll go through kind of the various disease states that are able to be treated through a telemedicine clinic. But you can set up days where the same room is in one day a pulmonary clinic, and then maybe that afternoon it's an endocrinology clinic, and then the next day it's a neurology clinic. But it can be a dedicated, almost multi-specialty approach towards care where patients do not have to leave the community. The physicians truly come to their community, but it can do it with regularity, right? As little as a half day or 2 hours a month, all the way up into 4 to 6 half days a week, really depending upon the needs of the patients and really kind of the demand. And so, a normal exam, a normal encounter, you run through the patient history, you do a physical exam, you discuss the diagnoses, and then you discuss the plan, you write prescriptions, and then the patient follows up. So the very same thing can be done through, and is done through, a telemedicine clinic, where patients can actually establish care and for years continue that care with the same provider, right? And I'll just skip here a little bit, and I'll talk to some of the types of clinics themselves, and then we'll open it up for questions. But I wanted to skip to the maternal fetal medicine. So being such a new field within medicine, there's not a lot of published studies, published data that's been reviewed. We were able to publish our very first review of patient care within our group in our maternal fetal medicine program. So maternal fetal medicine is a field of obstetrics that focuses on high-risk mothers and babies. And so patients can be deemed high risk because of different diagnoses that they have, such as diabetes, or due to age. And so as the demographics of mothers have changed, of pregnant mothers have changed, the risks have actually gone up. So there's a larger proportion that are considered high risk. And so having maternal fetal medicine involved has become a standard of care for mothers that are high risk. There are less than 2,000 maternal fetal medicine specialists in the entire nation. And so as you can imagine, most of them are focused in large urban communities, and it really requires pregnant mothers to drive. And so for every one of their visits, they have to drive, and that may be hours each way. And so as you can imagine, oftentimes they forego care, or they forego the follow-up care because of the inconveniences and just the difficulty of getting to the clinics. And so, again, this is published, the links down at the bottom, but our team over the last several years has monitored the mothers that they've treated in the communities through their telemedicine clinics, and we've seen a 94% reduction in the need for expectant mothers in the MFM clinics to actually leave the community for care. And so all of that care stays. And I think, like so many things, it's great for the mom to not only not have to travel and to receive that care local, but it's really important for the local hospital and the community to have the service, because there's so much care that's involved that doesn't leave. So mothers that are followed in an MFM clinic have very frequent ultrasounds done to examine the baby, the fetus, to make sure that they're progressing and there's no complications or issues. If they do notice any abnormalities in the ultrasounds, then that helps educate where we need to deliver. Do we need to deliver at a high-risk center, or are we safe to deliver here locally? But overall, 94% have been able to be kept in their home community, deliver in their home community, which is really important. And I think just kind of logically, it makes sense to the patient with diabetes, who may be difficult to manage, who needs to follow with an endocrinologist. If they can receive that care locally, then they're probably more likely to go, and that's what we've seen. And we definitely seen disparities in outcomes as you think about different disease states, rural versus urban. And so much of it is due to lack of access and just the difficulty of travel. You take off work, you may have to have someone take you, they have to take off work, and then just the time it takes. That expanding this care can be incredibly impactful. And so in our endocrinology clinics, we've seen dramatic improvements in diabetes management. Follow the blood levels, hemoglobin A1Cs, to watch those, and seen significant drops in those as they receive tighter and more dedicated diabetes care. Same can be said of pulmonary, as we treat patients with obstructive lung disease, such as COPD or asthma, again, receiving kind of guideline-based, attentive and regular pulmonary specialty care. You'll see improvement with less exacerbations, less need to go to the hospital. So there's a use case or kind of an experience to share about with almost every different specialty, but so much of medicine today is non-procedural. It is a patient with symptoms or a patient with a chronic disease who's assessed and then given a prescription. And that prescription may be a therapy, that prescription may be a pharmacologic agent, it might be a medicine. but so much. You can be incredibly impactful just through cognitive medicine, right? So you're thinking through a problem, you're discussing with the patient, and you're writing a prescription that's carried out by someone else. Very few patients, when you look at the total patient population, are actually receiving procedures. So that the impact and kind of the fit for telemedicine and virtual care is really great. So as I said, we generally partner with health systems or hospitals to help them build these clinics in their communities. And thus far, have seen experience, as I said, with MFM, endocrinology, to manage, for the most part, patients with diabetes and those with thyroid disorder, cardiology clinics to help keep cardiovascular care local, as well as assist with procedural studies such as heart ultrasounds called echoes, different types of stress tests, and now coronary CT. So virtual heart caths done through a CT scan, so patients don't have to go to a hospital that has a cath lab. And so all of that can be kept, and we do it in critical access hospital, the smallest critical access hospitals with an average daily census of 5. So when you think about, those are the types of communities that can have the impacts all the way up to larger communities. It really helps to kind of level the playing field and what's available to patients. And as I said, pulmonary and nephrology, so managing patients with kidney disease. We're launching our first rheumatology clinic in rural Arkansas here in the coming months. So it really kind of, anything that can be done cognitively, where we're assessing a patient, you really can lend itself well to telemedicine. And the last thing, which is probably one of the most impactful and probably most well adopted, aside from neurology clinics, is psychiatry. So just massive impacts on psychiatry and the ability to deliver psychiatric care to really wherever it's needed. So I will pause there and ask if there's any questions. Yes.
Could you talk a little bit about the specialists that work for you? Are they full-time doctors, full-time practice, retirees?
Yes, great question. So question was basically kind of little details around the physicians that work in our practice. So the average physician in our practice is less than 40 years old. He's right about 38, 39. The specialists are all US trained. They're all US based. The vast majority, we have 795 physicians in our group. About half of those are Texas based physicians, but all based in the US. And all are either board eligible or board certified in their specialty. So as physicians come out of fellowship, they're board eligible. They have a window of time, usually 6 to 7 years, to which they can take their board exams. And so that's a board eligible physician, or they're board certified, so they're within the board window. It's really important, I think, and one thing I didn't talk about is just the reimbursement model for a clinic. And so telemedicine today, everywhere, regardless of geography, is reimbursed by Medicare, reimbursed, and in Texas, reimbursed by Medicaid, and the payers have followed. Those in the urban areas, there's a little bit of gray on what's going to be eligible and what's not going to be. We don't have final rules on those for 2022, but we certainly know in the rural environments, before COVID, this was all eligible. So after COVID, it definitely will. And so these clinics survive off very typical and classic E&M codes, right? Where initial visits, follow-up visits, originating site fees. So again, it looks, feels, operates very similar to a telemedicine clinic. But in order to bill Medicare or any kind of governmental payer, the physicians have to be on US soil. And so that's a mandate so that these clinics can be billable. Yes, sir.
Good presentation. I actually like it when you're in the so,
thanks, John. Appreciate it.
One thing that you didn't talk a lot about, we actually saw as a bright spot in an otherwise terrible year, is on the inpatient side, where there was regional collaboration around bed capacity, or the small rural critical access hospitals stretched to keep more acutely ill patients, either because they couldn't get a transfer, or they're able to lean on telehealth resources like pulmonologists. And to their credit, they actually had good outcomes. So my question is, do you think that's something we'll be able to hold on to, or will we slip back into the status quo?
Yeah, I think the standard of care over the last decades has been for greater and greater specialization. And so as we've gone to greater and greater specialization, the hospitals with the greatest number of specialists or the broadest base of specialists really acted like Hoover vacuums to all of those who didn't have them and sucked them out of the communities, and they were centralized and kept in urban areas. And so I think what that's done is it's led to a lack of confidence in one degree, a lack of competence just because things aren't done, so you lose the skill. And then maybe a concern of what's the standard of care. You know, if you're a patient that presents to the hospital and you have chest pain and it turns out that you have heart failure, well, standard of care probably is you need to go see you need to be evaluated by a cardiologist at some point. And so those patients have now been transferred. And so habits develop and practice patterns develop, and those can be very difficult to disrupt or change because they're seen as standards. And John, to your point, COVID completely kind of shook the snow globe, and we're rebalancing. And our group saw an enormous demand for two things during COVID. One was pulmonary critical care to help assist management of patients on ventilators or those with respiratory failure, and infectious disease to co-manage a very difficult and challenging disease. And the normal transfer patterns across the state were completely disrupted, as you all know. And so hospitals that did not have ICUs are now managing multiple patients on ventilators. And that's not a competency that they have traditionally had, nor was it accepted as normal or maybe a standard of care for them to even try to do that. And what they saw is, I think probably what the more senior physicians would have told us is we can do that. And they did a phenomenal job. And internally, our group, again, a lot of the work we do is inpatient based. And we started with critical care, so it's one of our more evolved and mature service lines. Our critical care physicians, if you would have asked them prior to COVID, they would say, let's not even talk to a small rural hospital because there's no way we can build critical care programs in a small rural hospital or critical access hospital. And because our partners called, we answered, and we set up a cohort of hospitals across the state managing critical care inside of small, either rural hospitals or critical access hospitals. And it was an eye-opener for the physicians who now said, not only do we see that this can happen, is we wholeheartedly want to endorse it, and we need to go talk to more hospitals about helping them build these programs. So John, to your point, I think it's changed. It's opened everyone's eyes to, yes, absolutely complex, high acuity, very sick patients can be managed locally, first and foremost. But two, it's also really torn down the barriers to change. What is telemedicine like? Is it real medicine? Can we provide the same level of care? What will the patients say? All of those have melted away. And so it's really, I think, opened everyone's eyes, and it is truly a paradigm shift in what people think is possible and what the standard. So I think we'll see a dramatic shift over the next few years.
And that idea could save rural hospitals.
Absolutely. Yeah. Yeah. And as you think about kind of the ecosystem of care, and we've now been fortunate enough to build several of these within Texas, where you have multiple specialties inside of the hospital. So we have a couple of hospitals that have 4 to 5 telemedicine specialties. And then we have those same specialties next door in the clinic where the patients, after they discharge, can follow up, establish care, and then stay. And so all of that care stays local. The inpatient care stays local. The outpatient care stays local. All the ancillary services that are affiliated with that outpatient clinic stay local as well. And it takes time to build, and you attract and bring in those competencies and those resources. But after many, many years, it becomes really embedded and ingrained in the communities and continues to self-perpetuate. Yeah.
So these outpatient,
Yes.
did they just schedule?
Yes. So we've used very, I would say, standard and customary templates. We usually reserve a 4-hour block, either an 8 to 12 or a 1 to 5. We do as little as 1/2 day a month with a community. And the blocks of time are 40 minutes for a new patient and 20 minutes for a follow-up visit. So in a half day, typically it's about 8 patients that are seen. So even with low volumes, you can still have a clinic. As those volumes increase, you just add half days as needed. One thing we're looking at is sometimes even 8 patients in a half day or 4 hours is too much. And so we're actually working towards creating micro clinics that are 2 hours. So one community may take 8 to 10, and the other community may take 10 to noon. And so that doctor has 4 hours, but each only have 2 to commit to, 2 hours.
So would it be diagnosis specific? I mean, would it come in and say you have a 4-hour block?
Correct. Exactly.
But it's not during that.
Each has a distinguished half day. So community knows, or the referring provider base knows that, you know, every second Tuesday in the morning is cardiology clinic. And so as they see patients in clinic, they just refer, the template fills up, and then as those get full, if they begin to block out, well, we were doing a half day a month and now we're 2 months blocked out, it's probably time to add another half day. And then you just kind of grow as the demand develops over time.
So there's that minimum.
Exactly. Yeah.
What was the minimum broadband level of procedure that you see for the either visit or for that half-day block?
Yeah, it's a great question. So ideal is 5 megabits upload and 5 megabits download. That's the ideal. We've run as leaner than that. We've gone all the way down to 2 or so up and down, but 5 is ideal.
You said that we're the active positions in Texas, both that aren't as licensing. Then this year you got that figured out.
You can't move state medical boards any faster than state medical boards want to move. So it's a competency we've had to build just to approach that. But yeah, that's probably one of the larger barriers to scale in telemedicine. Absolutely.
Do you see any resistance from, so like we run a freestanding clinic, we're not hospital associated, but for instance, we're 70 miles from the closest endocrinologist and something we need desperately. So do you see resistance from local hospital systems that don't have that if they sometimes from you in the freestanding location?
No, we haven't seen resistance in that regard. One thing that we have seen resistance to is competition. And so really our group has always been aligned with hospitals and healthcare systems. And really our mission is to help keep care local. I mean, at the end of the day, that's what we're trying to do is to build programs that do that. And when we first forayed into outpatient telemedicine, it was an access physicians clinic. It had a big access physician sign. And we had one clinic in East Texas that was having 800 telemedicine encounters a month and across various specialties. And it was beginning to chew at market share of a client that was a partner of ours. And they let us know that. And so we've realized that kind of if we're going to partner, we need to be partners. So we work under the brand of the hospital or the community or the clinic we're working with, so that we essentially look and feel like we're part of that system. That's our goal, right? Because our goal is really just to see patients and help keep those patients stay local. And having our sign on the front door is not what we're in it for. And so that's where we've tried to kind of get rid of any of those barriers or perceptions of competition and really partner to keep patients nearby home. All right, any last questions?
Y'all offer any sort of like in-home help?
It's a great question. So we have traditionally drawn the line at a brick and mortar. There's tons of providers that do in-home. About 4 months before COVID started, we began to participate in the hospital at home model. So, which was really in its infancy prior to COVID. But then COVID really forced adoption of that model, and it actually became a CMS reimbursed model. So patients that met criteria for inpatient stay admitted to the hospital at home. So the hospital, all of the kind of logistics and tools and surveillance and actually people that a patient would see in a hospital actually come to their home. They set up a hospital home. So our group participates in the emergency medicine at home and hospital at home, where we're actually admitting and rounding on patients in their home, but they're actually inpatient status. And so that's I think a pretty wide open and broad field of telemedicine that we'll probably see explode here as hospitals are used more and more for specialty higher acuity, and the lower acuity, even though they traditionally would meet inpatient criteria, can be met at home. There's a lot of logistics that go into that, and it's incredibly inefficient right now, but definitely has a lot of promise. But that's where our group has kind of taking care of patients in their homes, still in an inpatient setting. Well, thanks everyone for the questions, and appreciate the time and the opportunity to talk to you today.